Today I will talk about secondary hypertension. First is a disclaimer. Caring Dogs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided here is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Friends, hypertension is a key risk factor for both heart diseases and chronic kidney diseases. Its prevalence is rising tremendously, and by the end of the decade, around 1.5 billion adults worldwide are expected to be hypertensive. Hypertension is mainly of two types: primary or essential hypertension and secondary hypertension. Secondary hypertension is because of some organic cause, and in primary hypertension, we don't have any cause. It is seen in 90 to 95% of the cases, and there is no underlying clear cause. Secondary hypertension is seen in about 5 to 10% of the cases, and it results from specific identifiable condition, for example renal, endocrine, or vascular causes. The secondary hypertension may be because of severe. We should suspect secondary hypertension when there is severe or truly resistant hypertension, if there is worsening of the previously well controlled blood pressure, when there is disappropriate target organ damage compared to the duration of hypertension. So, identifying and managing the underlying cause of secondary hypertension can significantly improve or even normalize the blood pressure. Hence, clinicians must be aware of common causes, clinical clues, and appropriate investigation to detect the secondary hypertension. We should always suspect secondary hypertension when the hypertension is severe, resistant, or when it presents early in life. The common causes are renal parenchymal diseases, renovascular hypertension, endocrine causes, and other also. Among the renal parenchymal diseases, the most common cause of secondary hypertension is renal parenchymal disease, for example, chronic glomerulonephritis, polycystic kidney disease. Here, the mechanism involved is damaged nephrons. They lead to sodium and fluid retention, which causes increased blood pressure. Second is the renovascular hypertension. It is due to renal artery stenosis, means there is atherosclerosis or fibromuscular dysplasia, which leads to decreased renal perfusion, and this leads to activation of RAS system, which in turn leads to vasoconstriction and sodium retention, and which further increases the blood pressure. Among the endocrine causes, primary aldosteronism contributes to secondary hypertension. Here, the patient has excess of the aldosterone in his blood, which leads to sodium retention, potassium loss, which leads to further hypertension. Patients with Cushing syndrome, they have cortisol excess, which also in turn leads to sodium retention and hypertension. The pheochromocytoma basically is a catecholamine secreting adrenal tumor. Patient has episodic or sustained severe hypertension. Thyroid disorders like hypothyroidism both contribute to hypertension. In hyperthyroidism, there is increased cardiac output, which leads to systolic hypertension. In patients with hypothyroidism, there is increased vascular resistance, which leads to diastolic hypertension. Patients with acromegaly, they have growth hormone excess, and there is increased vascular resistance, which also contributes to high blood pressure. Next, next is the coarctation of the aorta. Here, there is congenital narrowing of the aorta. Patient presents with upper limb hypertension with lower limb hypotension. It is seen commonly in children and young adults. Patients with obstructive sleep apnea, they may have a repeated upper airway obstruction during sleeps, which leads to intermittent hypoxia and sympathetic activation, which further leads to hypertension. Certain medications and substance abuse may lead to hypertension. For example, patients patients who use non-steroidal anti-inflammatory drugs for long-term use, they may have sodium and fluid retention, which further raises the blood pressure. Women who uses oral contraceptives, especially containing the estrogen, they have hypertension. Corticosteroid overuse can cause fluid retention. Certain decongestants, weight losing pills, they have sympathomimetic effects. Alcohol, cocaine, amphetamines, they are strong BP elevating drugs, and the drug abuse is commonly seen in young adults. So we should always review proper history, physical findings, drug use in patients with severe or early onset hypertension, or when blood pressure control is unexpectedly poor. When should we suspect secondary hypertension? When the age of onset is less than 40 years, or patient has late onset, that is more than 60 years of age, without family history or risk factor. Patient has a resistant or difficult to control hypertension, means BP remains high despite three or more drugs, including a diuretic. It may suggest an underlying secondary cause. Sudden worsening of blood pressure, sorry, new onset hypertension in a previously normotensive person, sudden worsening of well controlled blood pressure, especially suspicious in young patients or those more than 50 years without past hypertension. When the patient has associated symptoms like headache, palpitation, sweating, we should always think of pheochromocytoma. If the patient presents with muscle weakness, fatigue, polyuria, it may indicate primary aldosteronism or Cushing syndrome. Patient presenting with flank pain or kidney stone, it could indicate renal parenchymal disease or hyperparathyroidism. Leg claudication may point to renovascular hypertension. The physical examination also gives the clues. If on auscultation we get abdominal or flank bruit, we should think of renal artery stenosis. Unequal blood pressure in arm and leg, it may indicate coarctation of aorta. If the patient has Cushingite features like truncal obesity, moon phase, or stria, we should think of Cushing syndrome. Thyroid enlargement, it suggests the thyroid related blood pressure changes. Even the abnormal lab values or imaging may indicate or give us a clue for diagnosing secondary hypertension. For example, low potassium with hypertension, we should think of primary aldosteronism, raised creatinine, abnormal urine in new onset hypertension, we should think of renal disease, high catecholamines in the blood or the urine, they point towards the pheochromocytoma. Abnormal thyroid function test, we should check for hypo or hyperthyroidism. Young females, we should think of fibromuscular dysplasia. It is best picked up by CT or MRI angiography or renal Doppler. So we should always consider secondary hypertension when BP is unusually high and it occurs at a young age, or when it is resistant to treatment or shows signs of organ damage early. So again, uh, I will just tell the patient characteristics that should raise the suspicion of secondary hypertension. Younger patients, if they are less than 40 years of age with grade 2 or 3 hypertension, or hypertension of any grade in childhood, sudden onset of hypertension in individual with previously documented normotension, acute worsening of blood pressure control in patients who are previously well controlled by the treatment. When the patient has true resistant hypertension, if the patient presents with hypertensive emergency, when there is severe or grade 3 or malignant hypertension, when there is severe or extensive organ damage, particularly if there is disproportionate if the blood organ damage is disproportionate for the duration and severity of the blood pressure elevation. If there is clinical or biochemical features which suggest of endocrine cause of hypertension, clinical features suggestive of atherosclerotic renovascular diseases or fibromuscular dysplasia, clinical features suggestive of obstructive sleep apnea. If in patients with pregnancy, if the blood pressure is more than 160 by 110 mm of mercury, or when there is acute worsening of blood pressure control in pregnant women with pre-existing hypertension. So the diagnostic approach to secondary hypertension is, when should we evaluate the secondary hypertension? We should not screen all hypertensive patients for secondary causes, but we should evaluate if if the patient has early onset, that is less than 40 years of age, or late onset, that is 60 years of age. If the patient has resistant hypertension which is not controlled despite three drugs including a diuretic, when there is sudden or rapid rise in blood pressure, and even the clinical clues or lab abnormalities suggesting the secondary causes. These are the conditions we should always think of evaluating the cause for secondary hypertension. So, coming to the clinical history and physical examination, we should always ask about the symptoms like headache, palpitation, sweating. In the patients with hypertension, it may suggest us about the pheochromocytoma. If the patient has history of fatigue, muscle weakness, it may suggest of aldosteronism. If the patient has daytime sleepiness, snoring, we should think of sleep apnea as an important cause of secondary hypertension. If the patient presents with flank pain, history of kidney stone, then renal cause can be there. If the patient has unexplained weight gain, stria, moon phase, or other Cushingite features, we should think of Cushing syndrome. If there is history of medications like non-steroidal anti-inflammatory drugs, steroids, oral contraceptives, decongestants, and then drugs can be important cause for secondary hypertension. If there is past surgery or family history of polycystic kidney disease or endocrine disorders. If on examination we get renal bruit, it may indicate renal artery stenosis. Patient with obesity with stria suggests of Cushing syndrome. Thyroid swelling indicate thyroid dysfunction or thyroid disorder. If there is unequal BP in upper limbs and lower limbs, then we should think of coarctation of aorta. The basic lab test like decreased serum potassium may suggest primary aldosteronism. Serum creatinine and albumin, serum creatinine, increased urine albumin may suggest kidney disease. Thyroid profile may predict the thyroid disorders. So these are the specific tests based on the suspected causes. For primary aldosteronism, we should do aldosterone to renin ratio. For pheochromocytoma, we should do plasma or urine metanephrine or catecholamines. For renovascular hypertension, go for renal Doppler or CT-MR angiography. For polycystic kidney disease, do the renal ultrasound. For sleep apnea patients, we must do polysomnography, and before that we can evaluate the patient with Epworth scale or oximetry. For Cushingite syndrome, we should do low dose dexamethasone suppression test, and thyroid profile should be done if we are suspecting thyroid disorder. Imaging is indicated in patients with renal artery stenosis or structural disease. We can do renal ultrasound or Doppler. CT or MRI abdomen can be done for adrenal adenoma or pheochromocytoma. MRCT angiography is usually reserved for young women with fibromuscular dysplasias. So, important clinical pearls: when should we suspect secondary hypertension, which I have already discussed. The red flags for the patient's history are young patient less than 40 years of age with grade 2 or 3 hypertension, older patient with sudden or rapid worsening of the blood pressure, repeated kidney or urinary tract problems, episodic headache, sweating, anxiety, palpitation. We should think of pheochromocytoma. If the patient's lab value shows low potassium, muscle weakness, cramps may suggest primary aldosteronism, symptoms of thyroid or parathyroid issues. Red flags on physical examination, like cafe or late spots on skin, they may suggest neurofibromatosis or pheochromocytoma. Enlarged kidney on palpation, we should think of polycystic kidney disease. Bruit over heart or abdomen, think of aortic coarctation or renovascular disease. Cushingoid features, or when there are signs of acromegaly, they can suggest endocrine cause. If there is enlarged thyroid, tremors, dry skin, uh, deranged thyroid profile, we should think of thyroid dysfunctions. So, to conclude, secondary hypertension is less common than primary, but the important to detect because it can often be treated or even cured. Doctors should stay alert and suspect secondary hypertension in patients who are young, less than 40 years of age, or elderly if they are more than 60 years of age with new onset hypertension, if they have a resistant or suddenly worsening of the blood pressure, if they show unusual symptoms or clinical signs, for example, hypokalemia, renal bruit, stria, sweating. Early recognition allows for timely treatment of the underlying cause, improving the blood pressure control and overall outcome. Albert Einstein has said, only a life lived for others is a life worthwhile. With this, I conclude my today's topic. Thank you. Keep learning.